Good morning. I'm very thankful, along with Dr. Srinivas Kamath, with all the visionary leaders and dear colleagues for bringing GSICON 2024 to Calicut, to Trivandrum, to Kochi, and for giving us this opportunity. And we both are very fortunate to introduce Krishnan sir. Sir is a distinguished physician, and he was a very I was actually fortunate to be his student, colleague, and sir was always a mentor guide to me in all that I have been doing all these years. And sir is a most wanted teacher, clinician, and sir was actually instrumental in making us think that assessment in elderly is different and how it should be comprehensive, patient-centered, multidisciplinary, and targeting on the goal. So was our president of API. Sir has received multiple awards, Lifetime Achievement Award, and he holds significant academic positions. Sir is currently Sir was former HOD of Government Medical College, Kozhikode, MES Medical College, and sir is a teacher and a clinician attached to Baby Memorial Hospital. Over to you, sir.
Thank you, Chandani. I knew she would exaggerate, but I don't deserve a word of this praise. Thank you so much. I start by paying homage to my teachers, some of whom have influenced me throughout my life, gave me a good backing in general medicine, which helped me in my journey through geriatrics as well. In the UK, at Southampton, I worked with Professor M.R.P. Hall, and that was a great defining moment in my life. Neil Cartledge and David Bates, who you see on your left, were neurology teachers. All the others, most of you know. Thank you, Sajish and Balakrishnan, for asking me to speak today. It's a clinical topic which I thought I would share my own personal experiences with you. Let me start with my own mother. I had chicken pox. I very generously gave it to her. And when I came home from work in medical college, I found her totally confused and agitated. And we went through the list of all the problems that old people have. And it turned out that what she had was fecal impaction. She herself put a finger into her rectum. I was very young then. I didn't know the implications of all this. And on her own, she brought it out and she became well. Later, when I worked in Southampton, I realized the wisdom of this, that of this incident. Old people are generally obsessed by their bowels. It's a common statement, and habitual constipation is very, very common. But there was this head nurse and matron in Southampton who insisted on what she called debunging. And this would go on for 4 or 5 days on a regular basis, and the person would get better. I was surprised that I could replicate this in Calicut, in the hospitals I worked in, and many of them, you will be surprised to know, would get better once the bowels are cleaned. Of course, you would think of metabolic problems, confusion, dehydration, and constipation should immediately bring to mind hypercalcemia, metastatic bone disease, and multiple myeloma in an older person, and parathyroidism and others in a younger person. But the message I wish to bring to this group is that simple palpation is the best physical examination and the best investigation you can offer. And all you don't need an MR, you need a digital rectal examination, and an X-ray would give you a lot more information. At the other end of the spectrum, you have hyperactive bowel sounds, and you see the difference between the loaded colon and the multiple bowel loops. This is subacute intestinal obstruction. Hyperactive sounds, virtually silent abdomen. There was another man who came confused and constipated, and there was this mass there which was on X-ray what is described as a coil sign, and you see the coils, and ultrasound demonstrated that what he had was an interception from a malignancy. He got better. Now, pediatricians are always telling us that a child is not a little adult. And at the other end of the spectrum, we have old people with their own set of problems, medical conditions, management issues. So if your child had a fever, you would ask a pediatrician to see. If you had a cough or a fever, you would ask a physician to examine. If your parent or a grandparent has fever, you should be asking a physician for the elderly to examine. And assessment is very different, and which is what we'll try and go through. As aging advances, the physiological reserve of different organs, whether it's the heart, the brain, or the lung, changes, as does its physiology, presentations of disease, and definitely the response to management. And as they have multiple morbidities like diabetes, hypertension, stroke, there's a huge list of medicines that Tamanne yesterday showed us a list, a very devastating list of 20 or 24 tablets and medicines which the person is forced to take. How I would never be able to comply with it. I'm sure the old person has more problems. When I was in the UK, my consultant used to ask, Krishnan, what poisons are you giving this poor old man? And that's very true in every day of our daily practice. Drug metabolism and pharmacokinetics change. Polypharmacy compounds the problems, and there are multiple interactions that we must deal with. The other thing that happens in old people are the atypical presentations. You would think in a young person who has fever, it's easy to sort out whether it's pneumonia or a urinary infection or whatever that is responsible, and the fever is the striking aspect. But in an old person, please remember, he may present confused or may just collapse. And time and again, a myocardial infarction or palpitation would be picked up on the ECG and perhaps on an echo, and a fever would be pneumonia or a urinary infection or a gallbladder disease could be picked up on investigations, and the person may never have the fever. So it's like your vintage car. Initially, it runs very well. After a while, multiple systems are involved. There are many comorbidities, and they get affected sequentially, which is what happens to an old person. And this is a cycle which we must remember. You have an old person who's been coping reasonably well. He has been looking after himself, maybe going to the bank, even driving a car. He falls, fractures a hip, and that makes him immobile and unstable. He may have been on the floor of the bathroom or in the kitchen or wherever, and he might have had a hypostatic pneumonia or a bed sore, and then because of the immobility, he's unable to get to the toilet. He becomes incontinent, and then the infection makes him confused and incoherent. And what happens is that he is taken to hospital, where a young bright resident gives him something to quell the constipation, haloperidol or quetiapine, or in the earlier days thioridazine or whatever. He becomes more confused, and because he's been restrained, he clambers over the cot sides and fractures another bone. This is a vicious circle. This is what Professor Bernard Isaacs from Birmingham described as the giants of geriatrics, that one thing leads to another, the dominoes effect, as they call it. So the giants of geriatrics are the final common pathway. They do not kill, but decrease the quality of living. They make old people dependent, diminish the powers of recovery, eventually resulting in total care and nursing home admissions. He called them the giants because of the gigantic numbers of persons afflicted and the gigantic onslaught on their independence. So assessment in an old person is much more than history and physical examination. The young person, you're happy with an anatomical or pathological diagnosis, but you have to contend with giants, medical issues, and stretches your clinical skills and acumen to the maximum possible. So a grounding in medicine certainly helps. History taking in an old person is a fine art. It has to be focused, may need several sessions, and you have to be gentle and delicate. And of course, you have to rely on circumstantial evidence from carers or whoever to corroborate that history. It's generally believed that old people are poor historians. Now, the question is, who's a historian? It's the person who writes the history, not the person who supplies the facts and answers questions. Patients can never be bad historians. Perhaps it's the doctors who are. So, the difference between a young and an old person, history taking is very easy, and history is usually precise, and it's possible to time it. That I was in school and then I fell, or I had a fever, or I was at work, I went off work for 3 days. So it's easy to time. When an old person, history taking is difficult, often misleading. They have memory problems. They are rambling in the history, and the onset being gradual. The changes are very subtle, and it may be just the behavioral changes or the disheveled appearance that points to a clue that things are not quite well. So, taking history, you start with very simple questions. Let the person go on. It doesn't matter. Do not try to lead. You ask, as somebody yesterday mentioned, you ask him a pointed question, you will get an answer which doesn't really help. And unlike pediatrics, don't let the carer take over. The attenders are usually in a hurry to get out of there, but you need time. Reassure, verify accuracy. Now, one point to consider is to ask when the person was last well. When did he go out? When did he go for a wedding? When did he go to the bank? Whatever. And when he stopped routine activity like cooking for himself or washing or whatever. Old notes, you'll find there's a huge truckload of notes that they bring along, and they are usually jumbled up. I take time to sort them out. It takes about 10 minutes, but it's really worth the effort to put these in chronological order. A wealth of information comes out. It takes time, I'm sure. Old people are easily confused, frightened, and intimidated. Imagine yourself, a new environment. There's an inquisitor standing over you, hovering over you, asking you inconvenient questions very fast and very rapidly. And I may have memory problems. You can't expect me to remember all the details, or when I had a fracture, or when I had this pain, or whatever. So be charitable. And they may not even be able to explain the difficulties. How can you explain what it means to have a TIA, or a loss of vision, or a giddiness? What is. I find residents asking, did the whole world spin around you, or did you start spinning? It's all very difficult for an old person to recall. Please remember that. They are already in a state of panic. They may be worried or distracted. And the immediate response is, go away, don't trouble me. Physical examination is the other aspect, where you use all your senses smell, your eyes, your hearing, and most important, your palms to palpate. Physical examination is easy in a young person. A full examination is possible at a single stretch, but it may be pain or drowsiness or discomfort and may need several sessions. You're dealing with a very fragile individual, so handle with care. And your assessment is never complete without the activities of daily living and an assessment of the social and emotional aspects of the person. The most important thing is do no harm. There's a difference between knowledge and wisdom. My father had a left hemiplegia. He was mobile, he was okay. And then he fell and broke his right elbow. The immediate response was, we'll fix it. Bring him to hospital, we'll put a nail through. I took him to Professor Mani. I'm sure Dr. Paulos will remember. Professor Paulos will remember. And he said, Krishnan, now suppose we do a surgery or put him in plaster. He's already unable to use his left hand. You put a plaster on the right. You have a totally immobile person. He needs total care. Let him be. Let him use a mug or a glass. It doesn't really matter. It's not going to affect the healing. 6 weeks later, if the crack has not healed, perhaps we'll think of nailing. And in 6 weeks, lo and behold, the crack had healed. He didn't need the surgery. I think that's the difference between knowledge and wisdom. We all go by protocols. I hope we'll use our discretion more often. And we set unrealistic goals for the rehabilitation of persons. Maybe we should be a bit slow. And do we take all accounts of treatment into consideration? The compliance, you give them 20 tablets, one before, one after, one with food. How is it possible for anyone to remember? And what's the support system that they have, including occupational therapy, physiotherapy, or maybe medicines and all? And a domiciliary visit, we don't usually do in this country, but probably with old people living alone, we'll have to get into the habit of doing it. What are surroundings like? Is he getting adequate food? Is he getting medicines on time? Are the carers look after him? I remember seeing an old person on the 9th floor of a high-rise apartment in Southampton. And what happened is this person was living alone on toast and tea. Never before or never after have I seen a classical case of scurvy. For 6 or 8 months, he had no access to fruits. And that is the sort of deficiency which there would be, these are situations which all of us will have to face at some time or the other. Then there are the ethical issues. DNR, do not resuscitate, feeding, and your living will, and so on. But these are more relevant in the old than in the young. These have all to be taken into account. The difference between the Indian and the Western milieu is also we are fast keeping up with the West. If I have 2 or 3 minutes, okay. Pattern recognition is what happens. Is all what medicine is about. You have a person who is tall and thin, span greater than height. First thing you think of is Lincoln, and thereafter Marfan. But if this same person, as Professor M.G. Sadevan used to teach us, if he's mentally retarded or has a hole in his heart or has a prothrombotic tendency, it's homocystinuria that you would consider. That's exactly what happens is important to the old person, because peripheral neuropathy, the first thing you would think of is diabetes. Carcinoma comes much lower in a younger person in the list. If you are a vegetarian or if you had a gastric surgery, B12 deficiency must be considered. We often don't think about it. Bone pains are common in the elderly, osteoporosis and vitamin D deficiency. But if there's been nocturnal pain, which is distressing, and a pathological fracture, bony mets have to be considered. Bone pains with unexplained anemia and a high ESR should always bring multiple myeloma to mind. It's said, if you want to understand Homer, you learn Greek. To understand old people, you learn the language. If you have the skill and the expertise, you can become a good physician, but you need tact and patience also to become a good geriatrician. This is the story of my aunt who had a fractured neck of femur. She walked into the drawing room to supervise some function, and then she fell. Everybody ran around and said, "You're being careless." So the question is, which came first, the fall or the fracture? There's a good list that you would go through. Was there an obstruction on the floor and so on? Probably you'll hear about it more. Autonomic insufficiency, I'd like to point out, we are picking up a lot if only would think about it. And this is the story of a 74-year-old woman who would not respond. My PG was very, very bright. He said she was unconscious. I noticed her eyelids were flickering, so subtle signs are important. And I said, lift up your left hand. And up it went. What she had was a right hemiplegia and a motor dysphasia. What I would like to emphasize is be very careful about what you say in the presence of people who seemingly do not respond. There may be hearing problems and other things which will not, but I would like to, there may be pain or bewilderment or even dementia. I would like to bring out this fact, a short difference between delirium and dementia. If the change has been sudden or recent, you think of delirium. Stepwise, you think of dementia. If it's a global decline, it's dementia. And fluctuations and reversibility characterize delirium. Now, if a young person is young or old, if he is prone to bedwetting or confused, you have to rule out a seizure. This I would like to emphasize, 70-year-old doctor whose diabetes seemed to be under control had skipped a meal, blood sugar was low, hypoglycemia is very, very common, especially if they administered sulfonylureas or insulin. And that's something we must remember. This is an aunt of mine who had a torrential hemorrhage and again became very confused on third postoperative day. And it was my wife who was looking after her. And what happened is that M.R. Rajagopal, I had hoped to meet him here, was the anesthetist at the time. We called him in to put in another line. And he asked very innocently, is she on any medicine? I said very grandly, no. My wife remembered that she had been on alprazolam. And he pointed out that 4 days of alprazolam is enough to have anybody who, Shiva is here probably, and there are other psychiatrists too, who might corroborate this. This is the story of a person who was traveling with me from Calicut to Chennai. He seemed a bit distant. I knew him very well. Then I thought if he was high and mighty, maybe he could remain so. He lost his way in Chennai airport. He took the wrong escalator, the one that's coming up instead of going down. 2 days later, the daughter called to say that he was odd and confused.
So can you conclude?
I think so. I'll stop with this. And what he had was a subdural hematoma. Just one point. Bilateral subdural hematomas are easily missed. History of trivial injury is also usually forgotten. I thank you for your attention. We'll miss it. Thank you so much.
Thank you, sir, for your experience in treating geriatrics. Right. We can take one question or two questions if there are. So if there are no questions, thank you once again, sir, and thank you the organizers to give us this opportunity to chair this session along with Dr. Chandani. Thank you.
Thank you all. Thank you very much.